Okay, let's start by reviewing what we talked about on Wednesday. So we talked about MA, what it controls in the X-ray tube. Of course, it just controls the heating of the filament. Let's step back to kVp for just a second. So kVp in the X-ray tube controls the potential difference, that is positive and negative charges between the cathode and anode into the X-ray tube. So then it controls the speed with which the electrons travel from cathode to anode, controls the kinetic energy of those electrons so that when those electrons hit the anode, they have more energy to lose, which controls the energy level of the X-ray photon each one of those electrons will then create, right? So it controls the energy level, frequency, and wavelength of the X-ray beam. It indirectly controls the number of photons we create. We say indirectly because we say mass controls, directly controls. So it's direct in that as kVp goes up, mass goes up, but it doesn't have that inverse relationship. So don't confuse those two on a test. It doesn't have an inverse relationship where one goes up, the other goes down, like the inverse square law. So as kVp goes up, output goes up, but we use mass to be the controlling factor of that output. So when we get to MA, where we don't have mass yet, the only thing MA controls is filament current and how hot we get the filament, right? So it controls that. It controls the intensity with the electrons travel through the filament. We still just have filament current at this point. Generally, when we're talking about intensity, we're talking about intensity as it exits the X-ray tube. So mass to get MA together with time controls the intensity, the output from the X-ray tube. So in that way, it controls quantity. Specifically, it controls quantity of electrons that are going through the filament at this point. So as filament current is consistent, the overall MA that the station that you're using, if you remember back from last semester, is consistent except for on falling load generators, and that's the one where it starts off very high and just drops out to exposure. So we talked about what an amp was. It's just a whole lot of electrons. We talked about the effects on everything: potential, none; kinetic, none; beam energy. Beam energy is kVp, so none; penetration, none; frequency and wavelength, no effect. And so the only thing that it changes is current, right? So then we get to exposure times. Now we're actually making an exposure. The electrons are going across the tube and creating X-rays. So we talked about when we would want to use long exposure times for breathing techniques and things that you might see a word eventually that says autotomography. Okay, autotomography is just patient motion to try to blur out something so you see something better. That is your breathing techniques. The wagging jaws, things like that. Autotomography is spelled just like it sounds. So most of the time though, we're going to want short exposure time to control specifically involuntary motion, but it controls any kind of motion. Remembering that motion is the main thing that will destroy your image quality, and it's one thing that you have no control over. You can minimize the effects of motion, but you can't really control the motion itself completely. So we talked about mass in quantum model is usually the issue, but I did talk about potentially a component of time specific to quantum model. So proportionality to MA. MA in time gives us our mass. If we want to use reciprocity, they're inversely related. So then we talk about reciprocity, what it means. Law of reciprocity just means mass equals mass. It's give and take. One thing goes up by a specific magnitude, the other thing goes down by the same magnitude, and you arrive at the same result. So 100 mass equals 100 mass, and it doesn't matter what MA station and time you use in order to get to 100 mass. It should really give us the same thing. So now mass is the number of electrons we send across the tube. It's the number of photons that we create, and it controls the quantity, that is the intensity. And now we've got tube current. So we use it to control image receptor exposure rather than kVp because it's predictable. you increase by 100 mass and you get exactly 100, or if you increase from 50 to 100 mass, then you would exactly double the image receptor exposure. You double the patient exposure too. So we talked about tube current in context of changes in SID, and in this context, it was if nothing else changed, and we talked about when those things change. If you increase your SID and your phototiming, you're absolutely going to change mass, right? Because the phototimer is going to reset your mass. It's going to compensate for the increase in distance, and it should work out pretty closely to the inverse square law, or the direct square law rather. Direct square law, we'll talk about it in a second, but I think I failed to mention that sometimes it's referred to as the density maintenance formula. It really, more specifically now, since density is not controlled by mass, exposure, image receptor exposure is, and that's how we refer to what we once referred to as density. It would be the image receptor exposure maintenance formula. So a little bit more cumbersome. So, and again, if nothing changes, it's independent of emission. So if we make a change, be it by phototiming or we work the formulas to adjust it, then that's something different. But if the only thing that changes is SID, and I'm beating this dead horse because, you know, it's a question that's pretty commonly missed. It's independent of tube current. It's independent of X-ray emission unless you're phototiming or unless you change your mass. Okay? So, then we talk about the inverse square law and the direct square law, and we kind of put them together. Inverse square law works because what we do is we increase our distance, and because of the divergence of the central ray, the area that we would cover, cover increases by a factor of 4. So all those photons we would put in a small area now are spread out over a much larger area. We collimate back down to the small area, and if we doubled our distance, then that would mean that the intensity striking that small area would decrease by a factor of 4. So we would need to increase our technique by a factor of 4. Right, exactly. And almost universally at this point, that's going to be mass. So we're going to increase our mass, except for possibly in the examples that I've mentioned before. So how to spot inverse square law questions, what we're looking for is radiation dose. Most of the time these questions are going to come at you from the perspective of your dose is this at this distance. What is your new dose at this distance? The math, unless it came directly out of DeAngelis, if I wrote the questions for this semester, the math this semester, you should be able to work in your head. Okay? So, you know, your inverse square law, if you double your distance, then your intensity is going to do what? Four. Decrease by a factor of 4. And we're going to get there here in a second. We're going to decrease by a factor of 4. So all you got to do is divide your original intensity by 4, and there's your answer. Okay, so the math is pretty basic for this semester. When we get back into this in the sophomore year, we're going to make changes from 40 inches to 54 inches. So you're going to have to, you know, you're going to have to work problems. But for this semester, I just want you to know the concepts. I want you to know which direction and by how much. So rarely do we go from 40 to 80 inches. We go from 40 to 72 inches, and that factor would be 3.24. Right, now that really applies more to the direct square law than what it does the inverse square law. The inverse square law may be 1 foot, 2 foot. So in practice, how do you use the inverse square law? You're not really going to work it out, but considering what the inverse square law says, how do you use that in clinical practice?
If you need to increase your SID, you have to compensate.
Okay, that would be the direct square law. Yeah.
We want to decrease the radiation release, stepping away.
Bingo. You want to step back, right? So instead of hugging the table while you're doing a fluoroscopy, take a step back, right? Take 2 steps back if you can. And you can kind of play it off as, you know, you're right up against the table. Well, oh, let me get out of your way, you know? And then what did I tell you last semester? What else can you do to reduce your, hide behind the person who's making the money, right? So you step over behind the PA and you're looking like you're trying to see what the PA seeing or the radiologist, okay? So that's shielding. That's not really inverse square law, but that's shielding. All right, so what you're gonna look for is radiation exposure, you're gonna look for dose, you're gonna look for not mass. Okay, so if it's mass, then it's direct square law. So inverse square law is I1 over I2. So if you get a question that says, you know, what is this formula? I1 over I2 equals D2 over D1, then, and squared. Then what you're looking at there is, if you look, you know, it's I1 over I2, D2 over D1. What's that relationship? It's intensity, but it's inverse, right? So it's inversely proportional to the distance. So if you're looking at intensity, again, you're looking at inverse square law question, right? And it is a law, so if you double your distance, it's always going to decrease by a factor of 4. If you decrease your distance, it's always going to increase by a factor of 4, right? All right, so the direct square law is technique compensation, and it's the exact same formula. It's just instead of two things. Instead of intensity, instead of I1 over I2, we're going to say mass 1 over mass 2. All right, so if you see that, you really don't have to read the rest of the formula to know what that is. Mass 1 over mass 2 equals D1 over D2 squared. I'm asking you about mass. So what is that always going to be? Direct square law, right. So it's a direct relationship. Mass 1 straight across from distance 1, mass 2 directly across from distance 2. So that's going to be your direct square law. That maintains your image receptor exposure. So it's going to be mass. If you are phototiming, you don't have to do anything to work out the direct square law. The phototimers take care of it for you. And it is because of the inverse square law that we have to apply the direct square law. So back to that same question I asked before, you make an exposure on a small area, you increase your distance by a factor of 2, then that small area spreads out over a factor of 4, and then you collimate down to that original small area, then your exposure in that small area decreased by a factor of 4. You need to increase your mass by a factor of 4 to compensate for it, right? So you're just replacing the photons that won't be there when you increase your distance. All right, so if we go from 40 to 72 inches, that's going to be 3.24. How to spot direct square law questions? If it's asking for mass or technique change to compensate for a change in distance, that's going to be your mass. So your original mass was blah. What is your new mass at blah distance, right? All right, so that's one. What new mass should be used if you change your SID to, whatever. So look for image receptor exposure or mass changes with changes in distance to know how to work your direct square law or your density maintenance formula, okay? So square laws, most common mistakes are 2. 1, I'd say number 1 is forgetting to square the distances. All right, so you change your distance by a factor of 2, right? Inverse direct square law, either one. You changed you went from 1 to 2. That's how much of a change? It's a factor of 2, right? But 2 squared equals 4, right? So that's one thing that you're going to do. And I'm always, just being honest with you, always going to give you that answer on the test. You increase your distance by a factor of 4. Let's say you had 2 mass at 40 inches, you went to 80 inches. How much mass are you going to have? I'm going to give you 4. And some of you are going to answer 4, and you're going to get it wrong, right? Yes, you're going to get wrong. So you got to square it, right? So it's going to be a factor of 4, so your new mass is going to be not 4, but 8. Yeah, square the distance, not square the new mass, right? So it's going to be 8. All right, so that will be number 1, and number 2 is just working the wrong law. So you might plug mass into intensity and work the inverse square law for the direct square law. So you're going to go, you increase your distance from 40 to 80 inches, what's your new mass, and you go in the wrong direction. I'm going to give you that one too, okay? So one's going to come out of just left field. One of them is going to catch you if you work the wrong formula. The other's going to catch you if you forget to square. Okay? So always remember to square. Remember to use the right one. Okay. So those are our 4 kVp, MA time, and SID are our 4 prime exposure factors. Everything else is secondary. Focal spot size is really not an exposure factor in the sense that we expose the image receptor, the amount of exposure to the image receptor, the patient changes. All right, and I'll get more into that because there is one little thing that's going to be a hang up for you. So just kind of general housekeeping in diagnostic x-ray tubes, we have dual focus tubes. What that means is we have 2 focal spot sizes, but really what determines that focal spot size almost universally is going to be the size of the filament. So when you push the button for small focal spot, what you're actually doing is selecting larger small filament. So it's 1 bevel on the anode and 2 filaments to affect a change in the amount of that bevel we use to bombard with those electrons. Now, there are such things as dual bevel x-ray tubes. You'll never know if you use them one, all right? And if you do, they probably still have 2 focal spot or 2 filaments anyway. So those will be specialty type tubes. Conceivably you might see one of those in special procedures or somewhere like that. So most of the time it's going to be 1 bevel, 2 filaments. So common filament sizes are 0.5 or a half a millimeter. These are very small, and 1, 0.6, and 1.2, and then 1 and 2. So those are all variations of diagnostic tubes. There are tubes where we need higher inherent sharpness recorded detail, and that's what this, what it controls is sharpness recorded detail. I'm gonna try something. I don't know if this is not gonna work. That's too bright. Okay, so let's do this. Bring the lights back up. Okay, so the light that's on your desk, where's it coming from? The ceiling. Specifically though, 2, 4, 6. 6 times 3 equals 18, right? So 18 separate lights that are 4 feet long. Okay? So X-rays behave like light in a lot of ways, right? So if we've got light coming from, effectively that would be 24 feet of light times 3. That's a big area, right? So hold your hand over your desk. We did this last semester. What does your shadow look like? Yeah, pretty much what shadow, right? The reason you don't really have a shadow is not necessarily because you're not casting a shadow. You block light. It's because light's coming in from all different directions. Today's kind of cloudy. It's funny how this works out. Every time I talk about this, it's kind of cloudy. If you walk outside during a sunny day, what does your shadow look like? It's dark. It stands out real well. Got nice borders, right? On a cloudy day, what does it look like?
Depends on how cloudy.
Well, it depends on how cloudy it is, but let's say overcast.
Yeah.
Not much of a shadow. Why is that? Sunny day, where's the light coming from?
All from the sun.
All from the sun. On an overcast day, where's the light coming from? The entire sky becomes a light emitter. It's not as intense, right, as on a sunny day, but it's coming from everywhere. It's not that you don't have a shadow, It's just your shadow is obliterated because the light's coming in from a whole different types of directions. This is an extreme example, but the lesson here is the larger the focal spot, the 1.2, the 2 millimeters, the larger the focal spot, the less sharp the shadow, right? So if I turn those back off and I go back with my flashlight, so I want to turn this off. Oh, I really don't want to turn this off. All right, so over here, because I don't trust this thing, because it didn't come back up again today, and I don't trust my flashlight either. Okay, so what does my shadow look like?
Defined.
It's a pretty good shadow. Well, I can do it over here.
Yeah.
Duh. Yeah. So what does the shadow look like? Where is the light coming from? A little bit of area, right? So the smaller the emitter of any kind of electromagnetic radiation, the sharper the shadow is going to be, right? So large focal spot gives us a blurrier image. Is that bad? For the most part, yeah. It's not good. You know, we want the sharpest image we can get. But how small is 2 millimeters?
Pretty tight.
Pretty little, right? So what's the main thing that's going to kill your X-ray tube? Somebody said it, I think. Heat. Yeah, it's heat. All right, so we talked about this last semester. You know, we used the tungsten, and let's say you need to cram, I don't know, even a 1 mA, it's going to be higher than that, but 1 mA worth of electrons on a filament that size, and then you've got another filament that is, I'll keep my fingers out of the way, that size. Which one is going to have more heat on it per square inch? The big one or the little one? The little one, right. So where we want to use large focal spot is where we're going to have high heat loads. Two things. One, where we're going to have high heat load. So you want to use large focal spot on hands? You don't need to, right? What's your hand exposure? 2 mass, right? 2 mass, very low mass. You want to use large focal spot on abdomen? Yeah. Lateral T-spine? Yeah. Chest X-ray? Chest X-ray is still low exposure, right? But is it fine detail? Not really. You know, I mean, you want to be able to visualize lung markings, but in comparison to being able to see the cortex of the bone, is it, you know, I mean, the likelihood of being able to pick up a pathology in a single lung marking, almost non-existent, right? Your eyes just don't, it's not going to stand out, right? So even though it's not a high exposure, still a big body part, we're probably going to use large focal spot on chest X-ray. So where we need to see, one, increased sharpness or recorded detail. We want to see those lines without any kind of blur. We want to use small focal spot. But also where we're going to use high exposure, lateral T-spine, you know, lateral L-spine, things like that, we want to utilize the large focal spot. Where we want to see detail, we want to see small focal spot, large focal spot, high heat load, and where detail is not that much of an issue. Okay? So, we do have some special X-ray tubes. So we have modalities where we need to bring out sharpness or recorded detail more frequently than what we need to see. And it's more important to see that sharpness or recorded detail than what we need to see in the diagnostic room. So special procedures utilize routinely increased OIDs. Okay, so now I want to use this. Let me make sure that this will show it. Yeah, okay. All right. So let's say I have a set SID, try to get this bright, have a set SID and a very low OID. We get a sharp shadow, right? But if I increase my SID, what two things happen? Get magnification, so we get size distortion, and what?
Loss of reported detail.
Loss of sharpness of reported detail, right? So it gets fuzzy, and it gets big. All right, so the only way that we can keep that from happening really is to increase our SID, right? That's why we use 72 inches of chest X-ray, a lateral C-spine, AC joints. You know, pick another exam where we go 72 inches. We use it to decrease magnification and reintroduce sharpness of recorded detail. But in special procedures, in a lot of cases, what they do is they'll use C-arms, and for convenience, as much as anything else, they will put the patient's anatomy right in the middle of the C, okay? And part of the purpose for that is because if they're perfectly aligned in one plane to the anatomy, and the anatomy is dead square in the center, if they go to a lateral, it's still in the center, right? So they can rock it a little bit and keep that anatomy right where they need it to be. So what they do in special procedures sometimes are they'll use these, they call them coils, and they'll reinforce aneurysms in the small vessels in the brain. Okay, so you think it's important to be able to focus on that small anatomy and move just a little bit and not have to reorient your entire C-arm? And the answer is yes. So they used to use it, they increased OID for what we refer to as macro radiography, and that's still in your textbook. Macro radiography. Macro radiography is intentional magnification radiography. Okay, so going back to what I just did a second ago, we increase OID, we put it in the middle of the C-arm. What's going to happen to magnification? What happened is I back my hand up. It got big, right? So C-arm, you have an X-ray tube, and you've got an image receptor, which is an image intensifier, on the opposite ends, right? So you got X-ray tube, image intensifier, you put the anatomy right dead square in the middle, you have a pretty massive increase in OID, right? So increase OID, what do we do to overcome that magnification? Somebody said it, y'all are whispering today. What do? I already talked about it. Chest X-ray, increase SID, right. So you increase SID to overcome that magnification. But what if they did that? What, you know, you got your C-arm, which you can't really do this with a C-arm, but you got your anatomy in the middle, so they want to overcome that magnification, so they increase SID. Now when they go to a lateral, they're not lined up, right? They don't want to do that. So it's intentional increase in OID without an increase in SID. It's macro radiography. Originally, the purpose for that was two. One was what I just talked about. Two was to increase the size of the image. Does it still increase the size of the ratio of magnification? Well, yeah, but the display might be unchanged because now everything is processed through the computer, so it might not show as much magnification on the image as what it did before. You can digitally magnify it, right? But if it doesn't show that magnification, is there still a loss of sharpness of reported detail? The answer is yes. So that was a long walk to get to this. Because of the inherent loss of sharpness of recorded detail, file the word macro radiography away in your mind. That's an intentional increase in OID without an increase in SID to affect a magnified image, to give you a magnified image. But really, as much as anything else, what we're going to use is what we refer to as a fractional focal spot. So their smaller focal spot is going to be smaller than our smaller focal spot. Okay? Yeah.
How is that different than the air gap technique?
Good question. Okay, so the air gap technique, we have an increase in SID, right? But we also have an increase, we have an increase in OID, but we also have an increase in SID. That's the answer to the one of the answers on the question as well. The air gap technique specifically though is not to magnify. We're going to increase our SID to overcome the effects of magnification. And the air gap technique works like a low ratio grid. And how it works like a low ratio grid is this. Say I take an x-ray at 40 inches. SID doesn't really matter at this point. Say I put my image receptor right up against the patient's neck right here. And we've got wide angle radiation created in the neck. Is it going to hit the image receptor? Yeah? If I put it out here, will it hit the image receptor? No. So where the air gap technique is the scatter radiation, sum of the scatter radiation that scatters off at a wide angle will miss the image receptor. So two differences. One is with macro radiography, we do not increase SID. With the air gap, we do. And number two, the purpose for the air gap is to get rid of some of the scatter radiation. We increase the SID to overcome some of the magnification. Okay? So one of the main purposes for macro radiography is to have the magnification. When we have an increase in OID and presence of air gap, we increase SID to get rid of some of the magnification. Okay? So don't miss that on the test either. Be it this test or in the spring semester. In mammo tubes, what we're looking for is what we refer to as microcalcifications. So breast tissue is, all soft tissue with ducting going through it. Just not a whole lot to see in there. And what we're looking for are little bitty tiny specks and deposits of calcium that are, if you take your pen and you dot it on your page, maybe that smaller, okay? So again, if we have a large focal spot size and small anatomy, what's the shadow going to look like? Oh, very good. So what we have to have is a very, very small focal spot size. So now we're down to the large focal spot being as big as a small focal spot on fractional, right? And a small focal spot being very, very small. So it's a fractional focal spot, microfocal spot in mammo, fractional focal spot in special procedures tubes. Both bring out more sharpness and recorded detail, but especially mammo. Okay? Now, why do I say that this is, or why do we say that this is secondary exposure factor? Yeah, well, you can. You can select large and small focal spots, so you can control it. But kind of like reciprocity, in a way, what's 100 mass off a small focal spot versus a large focal spot? 100 mass, right? What's 100 kVp on a small focal spot versus a large focal spot? 100 kVp, right? So in as much as changing the quantity or quality of the x-ray that's coming out of the tube, focal spot has no effect. With one distinct, possible difference. It's not really a difference, but if you're not paying attention to the question on the test, again, it'll kind of trip you up. That was a Freudian slip, trick you up. That is this. Let's go back to diagnostic tubes. So if you select small focal spot and you've got somebody you're shooting a cross-table lateral L-spine on in the ER, the patient's hypersthenic, and you set a technique of 85 kVp, 200 mass on this patient, and you select small focal spot, it's going to give you tube overload. It's not going to let you shoot that. If you select 400 MA station on a small focal spot, it's going to give you tube overload. It's not going to allow you to make that exposure. Okay? That's not the same as if you make an exposure at, let's say, I don't know, 75 kVp at 20 mass on 200 mA. Both large and small focal spot sizes will give you that exposure, and the difference in image receptor exposure should be identical. Okay? So if the machine will allow you to make the exposure, there should be no difference in exposure between large and small focal spot. It should be identical. Okay? If the machine won't allow you to make an exposure because you selected 400 mA on a small focal spot, or you selected a big exposure on a small focal spot, then you don't get an exposure, right? So, you know, if you run into a question on test that asks what the difference should be between exposure on a large and small focal spot, your answer is, shouldn't be any, right? But you may have an answer on there that says you can't get exposure over 200 mA. So what's the difference in that? In one, you get an exposure. In the other, you don't get any exposure, right? So your answer is, should be identical, should be the same. Large and small focal spot exposure should be the same. As long as the machine allows you to make that exposure, should be the same. Large, small focal spot. Okay. So, we're going to talk about this again in your sophomore year. Everything that we do, every setting that we have, kVp, mA, time, focal spot size, SID, beam perpendicularity, collimation, everything has a quality control test. So your MA stations should be accurate and should be proportional to the next MA stations. Your timers should be accurate, but there are variances, that's variances for each one. And that is that your machine's never going to be, I won't say never, but every machine is never going to be perfectly on point with every one of your exposure factors. So you have a variance. All right, so notice though that the smaller the focal spot, the greater the variance, just because it's kind of hard to control. You know, you stack, you know, trillions of electrons on a smaller focal spot within probably a larger focusing cup, and you make your exposure, they're going to spread out, right? If you're on a larger focal spot and the focusing cup is right on top of it, they're probably not going to spread out quite as much. Plus, the collection of those electrons on the larger focal spot are already more spread out than what they are in a small focal spot. So naturally, your smaller focal spot sizes are going to have a larger variance than what your large focal spot is. So, you know, every year, a physicist or biomed guy, probably a physicist, is going to come in and do quality control on your machines. Okay, and I'm going to measure everything. So if you have a focal spot size is 0.8, then your variance is never going to be smaller than 0.8, but it could be as much as, that would be a 1.2. Okay, so is 1.2 smaller than the next small focal spot size? Yeah, so it's, you know, there's still a benefit. And then, you know, that 1.5 could be as much as 2.25, right? So if it doesn't test at, you know, exactly what the focal spot size is, that's okay. Okay. So focal spot size effects on image receptor exposure, none. Effects on penetration, kVp, mass, none. Brim spectrum, none. Any questions on focal spot size? Okay, so we've got about 5 minutes left. See if we can get through filtration. So filtration, we've really got two types. I know I've got kind of three up here, but we really have two types. as inherent filtration and additive filtration, and compensating filters are just a form of additive filtration. I left them in 3 separate categories because compensating filters, we have a number of different types of compensating filters that we use for different purposes. So where we have inherent filtration, we've got filter for our purposes. What we're going to say is that inherent filtration is anything that brings us up to what we have to have in order to legally make an X-ray beam and expose a human. Okay, that's 2.5 millimeters of aluminum if the machine is capable of shooting above 70 kVp. Okay, 2.5 millimeters of aluminum. So what all goes into that? Everything that the X-ray beam passes through before it hits the patient. So that would be the glass or metal envelope is one, and then the oil to cool the X-ray tube, and then the port in the protective housing, and then the back of the mirror, and anything, you know, if all that gets you up to 2.5 millimeters of aluminum equivalent, and that's the EQ at the end of that, if it gets you up to 2.5 millimeters of aluminum equivalent, then you don't need anything else. If it doesn't, then you need something else to get you there, right? So it's got to be at 2.5 millimeters of aluminum equivalent. And what they'll use is just sheets of aluminum, just add it above the mirror. So a couple of things about inherent filtration is that, you know, if you're operating above 70 kVp, it's 2.5 millimeters of aluminum, and includes all that stuff, all the way up to 2.5 millimeters of aluminum. But also inherent filtration increases with the life of the X-ray tube. We talked about it last semester. What happens as X-ray tube ages? Tanning of the tube, exactly. You vaporize a filament, maybe a little bit on the anode, coats the inside of the X-ray tube, adds a layer of metal, and increases inherent filtration. So again, your engineer, your physicist is going to come in and let's say an exposure that you made a year before at 10 mass gave you, just to keep it simple, 10 MR of exposure. It'd be more like about 50, but 10 MR of exposure, we'll say. And this year, it's only giving you 9. So what happened? Well, tanning. We've got more exposure. That 9 that's coming out is of higher quality, but it's still 9. So we want it to be at 10, so they'll get in there and they'll tweak the settings on the inside of the X-ray tube and bring it up so that it's shooting accurately. Again, it gives you 10 MR worth of exposure. Okay, so that's inherent filtration. Additive filtration is anything above the 2.5 millimeters of aluminum. And it can include compensating filters, but let's say, we don't do this anymore, but a long, long time ago, this was before, you know, I started taking x-rays, they would use tungsten tubes for mammography, and there's just no reason for it. You get no characteristic that you would expose a breast to out of a tungsten x-ray tube. You know, the kVp that you're going to be using for mammography, if anybody goes into mammography, is like 30, maybe no more than 40 kVp. Where's our characteristic spectrum? I recognize characteristic spectrum. 69, right? So they're going to use a molybdenum target in mammography. So the Brim spectrum completely changes and all that. But if we, okay, so here's another example though. Pediatric patients. Pediatrics, in pediatric hospitals, they might want to filter the beam even more than what the 2.5 millimeter minimum is to reduce patient dose. The higher the average, kind of like kVp, the higher the kVp, the less absorption in the patient, the safer the beam is for the patient. Or filtration, remembering that filtration is one of the first things we use to minimize patient dose. If we increase the inherent filtration, the beam becomes more safe, right? So in pediatric hospitals, I don't know that this is 100% true, but they might use more additive filtration, okay? So that's just straight additive filtration. A subcategory of additive filtration would be compensating filters. And we don't see these a lot anymore because our computer processing compensates for our tissue density differences. But back in the day when we used to shoot feet, T-spines, anything that had a very steep wedge shape to it, you had to shoot where the patient's pain was. Okay, so and it's still good practice. Get the history from the patient, annotate where the patient's pain is. I always used to carry a pen around with me, and if pain could be specifically identified, I'd put the pen on the image receptor pointing to where the pain, the patient said pain is right here. I put the pen, so it's pointing to it, just an ink pen, So what we would do is, for those wedge-shaped structures like feet and T-spine, is that we would use a compensating filter. A compensating filter compensates for tissue density differences that would interfere with being able to make a diagnosis across the entire anatomy. Okay, so your foot being wedge-shaped, the proximal end of your foot towards your heel is going to absorb more X-rays than the toe end, right? So if the patient complained of pain in the toes, on the toe end, then you would shoot with a totally different technique than if the patient complained, they say I dropped something across my forefoot, the proximal portion of the foot. You'd use a different technique for that. The problem is if you shot for the toe, your film was too light for the forefoot, and if you shot for the forefoot, it'd be too dark for the toes. Your computer really kind of takes care of all that. You don't burn out the toes if you shoot with a foot technique anymore. So has anybody ever seen a wedge filter in a hospital? Probably not. So the places that you might see these now, maybe the only places you might see it now, would be if you do a rotation through a clinic that does like scoliosis series. A scoliosis series will use, and it's not really a compensating filter as much as it is added filtration, and not really even added filtration, but more efficient collimation essentially. Okay, so what they'll use is basically what we refer to as a trough filter, and a trough filter is kind of like a double wedge. And what we'll do in scoliosis series, I know we talked about this at the end of the semester, last semester, but we'll do a number of things for scoliosis series. Because our demographic for scoliosis series, or patients with scoliosis, is generally young women with developing breasts, we want to minimize the dose to those breasts. So what we'll do is we'll put these trough filters on, which are basically double wedges, and they go on the image receptor, or I'm sorry, they go on the x-ray tube, or at least between the x-ray tube and the patient, right? And the purpose for those is to limit the beam. You can shoot through the collimators. I mean, collimators aren't as efficient as what we think they are. You can have an exposure that goes straight through those collimators. But anyway, we'll collimate in and then put the wedge filters, the trough filter on, double wedge, and we'll shoot the patient PA in order to minimize that breast dose to the patient. So you might still see compensating filters there, but we used to have them to even out tissue density differences, and those are your key words: even out tissue density differences. Those are compensating filters, or trough filters for to minimize breast dose in scoliosis series. Compensating filters. Okay, added filtration. Generally, if the question doesn't have any kind of qualifier, added filtration, just more sheets of aluminum. Okay? Compensating filters compensate for something. Breast dose, tissue density differences, something like that. Still added filtration. Doesn't come inherent in the x-ray tube, but it's kind of its own subset. Okay? So any questions on that? Because we are officially out of time. We'll talk on Wednesday about filtration and its effect on the brim spectrum and all that. We kind of touched on it already, but we'll talk about that next week.